Dear colleagues, I would like to welcome you to the next session, and this is a session on precut. When we look at the precut, we have to mention the transpapillary approach to the bile duct is still the most natural approach in order to perform interventions at the bile duct. But the question is always, what shall we do when ERCP fails? There are a lot of new presentations and data on EOS-guided approach, but I think if we have the situation of a failed ERCP, I think the next step is to perform a precut. However, there is the widespread argument that precut should be only performed by experienced endoscopists, but the question is why? Is there a lack of teaching? What is the problem? And I'm now very honored to welcome one of the most outstanding pioneers of ERCP and interventional endoscopy, my teacher, Professor Nip Soehendra. And at this moment, I know we have 668 people in the internet, and there are a lot of former fellows from UNIP, especially from South America and Asia. And please, Nip, tell us, what is the problem with precut, or do we anyway have to rethink about our approach at the papilla?
Ladies and gentlemen, first of all, I would like to thank Stefan, of course, for inviting me again to his prestigious live meeting. I think this time is the number 7, yeah. And furthermore, I feel very honored to be one of the expert group here on this session. When Stefan asked me to give a talk, I had answered him promptly and accept his request, because after listening and reading so many presentations in the last 50 years, I feel a need to talk about this issue, not only primary precut, but more importantly about the issue how to prevent this persisting complication of ERCP or EPT, the so-called PEP. And this time I have probably a very debatable vision, which I would like to share with you all. Now it is widely accepted that PEP is mostly caused by traumatization of the papilla, and especially of the pancreatic duct and pancreatic orifice, resulting from repeated biliary cannulation attempt. Several trials with pharmaceutical aids have failed to prevent PEP, and only rectal administration of NSAID may moderately reduce PEP. That is the reason why the recent guideline of ESGE has recommended the use of rectal NSAID prior to ERCP or EPT in order to reduce the PEP. Historically, in the early stage of ERCP, you know, starting at in around 1968, 69, there were no ultrasound, EOS, and MRCP available. Therefore, diagnostic ERCP has been considered a mandatory requisite for EPT. Today, as you all know, indication of EPT is made based on the result of EOS and or MRCP, so that biliary cannulation and contrast injection prior to sphincterotomy may become obsolete. However, deep cannulation of the bile duct is still required because we like to avoid hazardous zipper cut, and this can be only realized by doing the EPT with a Y-guided. The key question is therefore, how can we gain atraumatic access to the bile duct? That means real selective cannulation of the bile duct without to cannulate the pancreatic duct. Let us take a look to the anatomy. We know that in vast majority of the cases, biliary and pancreatic ducts join the ampulla of Vater. That means both ducts mounting in the papilla or in the ampulla. And that's why the orifices of these two ducts are invisible endoscopically. This is the explanation why cannulation of the bile duct through the papilla may require several attempts. And we know that from several publications that the immediate success rate of biliary cannulation without to touch the pancreatic orifice is only around 70%. Repeated cannulation attempts, which are associated, as I said before, with increased risk of PEP, are avoidable if the orifice of the desired duct, in this case of the biliary duct, is visible. This picture showing you again the confluence of the biliary and pancreatic duct in the ampulla. Zeige. Moment.
Next. Nee, zeigen geht nicht. Zeigen nicht.
Okay. And you can see that here, the ampulla, the length of this ampulla, according to our previous study based on 50 postmortem specimen, is not longer than 15 millimeters. That is, it looks usually during the duodenoscopy that the papilla appears larger than its true size. And you can see again at the bottom of the ampulla, the orifice of the bile duct and the orifice of the pancreatic duct. You see that this duct is hidden. They are hidden in the ampulla, so that we cannot cannulate the really selectively without to cannulate the pancreatic duct. The blue broken line indicate the length of the roofing of the papilla. I will call it Ampullotome. And you can see how far this Ampullotome, or the previous term was precut, how far should this Ampullotome go until the biliary orifice can be identified. Consequently, to enable immediate successful cannulation of the bile duct, we need to see the orifice of the bile duct. And this is only possible if you open the ampulla. I call this procedure as Ampullotome. I like to avoid the use of precut. I will tell you why. The opening of the ampulla must also be diathermically atraumatic to the pancreatic orifice. And you will see that it is possible, and but not using the needle knife. Using this instrument, Ampullotome, my favorite instrument for doing so-called precut. This is actually a modified Erlangen type of sphincterotome, with which we all familiar. And it has only a short tip and short cutting wire. Here you see the principle of ampullotomy. You see that the instrument is inserted in the orifice of the ampulla. And you can cut this ampulla, open the ampulla, with the tip of the instrument anchored in the ampulla, so that the cut can be done under better control. In contrast to needle knife precut, the cut cannot go wrong, and misdirected cut is impossible, especially if there's a peristalsis movement. I will show you later in the video, and explaining more clearly what I mean. And by this way, when you open the ampulla, then you can see the biliary office and the pancreatic duct office as well, which is normally located at about 5 o'clock. And you see again in the picture that the orifice of the pancreatic duct is always protected from the diathermic heat by the catheter itself. On this advantage, we doesn't have if we use IT knife. Now I will show you one example. This is a normal papilla measuring not more than 15 millimeters, and it's nice. And the ampullotome is already inserted in the orifice of the ampulla. And please remember the time of the start of this procedure. That was about 7 minutes after 12, because we like to know at the end how long the procedure of this ampullotomy will last. Now we run the video. You can see that the cut is really very well under control. Cannot be compared with those with the IT knife. I prefer to use pure cutting current, but endocut models can also be used. And you see that the clock, it is now 12 o'clock, 12 minutes. That means in less than 5 minutes, we could see the orifice of the bile duct. Now the cannulation of the bile duct is performed under the guide wire in order to allow better control cut over the guide wire. The next video example is dealing with a smaller papilla. In such cases, of course, we need fewer cut, because the papilla or the ampulla is much shorter. And the same procedure we will do now. You see, very quiet. The cut is really under control, because the tip of the instrument is anchored in the orifice of the ampulla. Bile coming out, indicating that the orifice will be soon visible. Now we extend a little bit more the cut. And in this case, I think we finished the ampullotomy within 3 minutes. And soon you will recognize, identify you see the orifice of the bile duct there? Now, regular, standard, Y-guided cannulation can be done. So, this picture is very interesting. This is taken immediately after the biliary sphincterotomy with a prior ampullotomy. And please focus in the area of about 5 o'clock. This is the orifice of the pancreatic duct. You will see as a proof that the pancreatic orifice wasn't injured by the diathermy while doing the ampullotomy. You can see the function of the pancreatic sphincter remains, and you may also observe that a little granule came out from the pancreatic duct. By that you see the granule, the pancreatic sphincter is open now, and at the end close again. So after watching this video, I would like to ask you what you prefer, needle knife or ampullotomy. I give you some comparison here between the two techniques, and we can see that the use of ampullotomy, because this is actually a diminutive of the standard sphincterotomy, it is everybody who is doing ERCP should be familiar with this instrument, and that's why the use of this instrument is easier to learn. And my recommendation is this technique should therefore be included in a training curriculum. Perforation practically never occurs because we only cut the roof of the papilla. We start from the orifice and never exit the cut until the exposure of the biliary orifice. And the precut with needle knife, we know that is associated with a certain risk of perforation. And it is actually a freehand technique, and therefore it's more difficult to learn. It's no wonder that this needle knife precut is recommended by many senior ERCPs to be used only by experts. Unfortunately, this Ampullotome is still not yet commercially available. Before that, I heard from Stefan Groth that he's using a regular sphincterotome, but he cut the tip of the sphincterotome, so use it as a ampullotomy, what I have shown you here. This is the same, so you don't need a special instrument, I guess. This is the result of needle knife papillotomy published by the Amsterdam group, the group of Kees Hubrecher, which is known as a strong advocate of needle knife papillotomy. You see in their hand, experienced hands, perforation occurred in 3%. And this perforation rate may be higher if one started doing the needle knife precut from the top of the papilla as a fistullotomy. The initial success rate of CBD cannulation after needle knife precut was in this study 88%. But at the end, they succeeded almost in all cases the biliary cannulation. The next slide shows you a summary of several publications about IT knife, about needle knife precut in conjunction with the frequency. All these publications, except one, Hubrecher at the bottom, came from the US. Interestingly, you can see that the higher the frequency of precut, the lower is the complication rate. The higher frequency reflects not only the experience of the investigator, but also the early use of precut. We know the early the precut is used, the lower is the complication rate. The relatively high incidence of complication, I think, especially during the period of SOD hype and of the overuse of the sphincter OD manometry, has led to a very bad image of the precut, which still remain in the heads of some senior American ERCPs until today. Peter Cotton conclusion, you know Peter Cotton, very famous ERCPs, and is the opponent of needle knife. His conclusion is best described in this letter, which he wrote to the editor of the journal Endoscopy, commenting the paper of Amsterdam. He said, needle knife precut sphincterotomy is not a substitute for standard sphincterotomy technique, nor for poor expertise, and cannot be justified in patients with speculative sphincter dysfunction. And the title of this letter to the editor was Needle Knife Precut Sphincterotomy, the devil is in the indication. I would say today, the devil is not in the indication, the devil is in the instrument. And for the Ampullotome, what I'm propagating here, I think one could say also a better idiom according to the original idiom of this sentence. The devil is in the detail was the original one, but the original one was not the devil, but the God is in the detail. I would say that for the Ampullotome, that the devil and the God is in the Ampullotome. Now, my personal recommendation is we should change the current practice cannulation technique, the standard technique, with wire or without wire. We should leave all this conventional, practically blind cannulation of the technique, blind because we don't see the orifice, in order to avoid PEP, and forget all the rescue technique, including the transpancreatic duct biliary access, and of course, forget the needle knife. Use the Ampullotome. Consider exposing the biliary orifice as the first step of EST. So the Ampullotome is the first step of EPT instead of standard cannulation technique, which is practically blind. And only if you see the orifice of the bile duct, you can have a direct access to the bile duct by a visually well-directed cannulation, no injury of the pancreatic orifice, no risk of perforation. This is my last slide showing the algorithm, but I would like to recommend to you. Ampullotome, first step of EPT instead of standard cannulation, in order to identify the orifice of the bile duct, allowing for selective cannulation with Y-guided symplectomy, and the final step of the procedure is, of course, Y-guided, always Y-guided sphincterotomy in order to prevent zipper cut. And this is, in my opinion, the way to prevent PEP. This is my last slide. Thank you very much.
Thank you, Nip, for this visionary and provocative lecture, I can say it. And we will discuss this lecture, but I think we have to go step by step. I think first it is important to somehow to define the current approaches in the different centers in the world